All right, Dr. Ben Fine. So you're the Director of Quality and Informatics at Trillium. You're also a clinician scientist at Institute for Better Health. And more importantly, you're the AI chair at the Department of Medical Imaging, University of Toronto.
The problem is the kind of that last mile, the edge cases, the what happens when these models don't perform well, and what guardrails do you need to put in place?
Yeah, navigating this is kind of very tricky, interesting, and exciting at the same time.
You know, what you do on a daily basis now to somebody 50 or 100 years ago is, you know, complete science fiction.
So let's start with the elephant in the room. There's this very famous quote by Jeff Hinton, Nobel laureate, who predicted the future. This was kind of back in 2015. And he said that we should stop training radiologists because the specialty is done. In 5 years, radiologists are going to be replaced. It's been 10 years since he said this quote. Things have definitely changed. We know that, as with anything, like Elon Musk promised us self-driving cars, and back in the day, back in the future, they promised us flying cars by early 2000s. But we know that hope is always there and things are always changing. So what do you think of that quote now? And where do you see things evolving as they go?
Well, first of all, Satish, appreciate you inviting me, and kudos for putting this podcast together, because it's a pretty awesome way of sharing what you and other teams are up to. I think for me, with the Hinton quote, I joke about it every time I'm thinking about when I'm on call in like the middle of the night. I'm like, come on, why couldn't he have been right? Right? There are many tasks that radiologists, and they will tell you, don't need to be doing, don't want to be doing, that AI could be doing, but he has disappointed us, right? In the short term.
Yep.
And I think that's an important concept too, right? I think it's Amara's law, right? We tend to overestimate the impact of big technology changes in the short run, but underestimate in the long run. Yeah. I think we're going to see the same thing with AI in radiology, because yes, exactly what Hinton had prescribed isn't happening within the first 5 years. But you can see a lot of sea changes, and hopefully we'll talk about them, that are really starting to nip away at some of the tasks that make up the job of a radiologist, that really can transform how we deliver care. So I think if you look to the long term, and we can totally get into it, there will be changes to our practice. There already have been and are. And what's most important is that, when you listen to Jeff Hinton, he's a great example, because he understands the neural network well.
Absolutely.
And that's just what he's thinking about. You can see his neurons firing, and, wondering how these weights interact and how they should be structured, and how should we feed it back, and et cetera, et cetera. But what he doesn't even care to think about, and you can see it if you ask him questions. I remember vividly at some conference, maybe 5 years ago now, somebody asked him, well, this is nice, but how do you actually envision some of these tools being deployed in radiology or medicine? He's like, oh, I don't know. That's for somebody else to think about. Right? And I think that's our job, is to figure out how do we actually adopt these tools. And I think that's one of our advantages, as we've kind of chatted about offline, is, if these tools are going to work in the real world, somebody's going to have to figure out how to do it, and who's going to figure out how to do it better than the people doing that job already. And I think that's the radiologist.
Absolutely. So currently, as you point out, there has been a lot of changes in the last 10 years. What areas of radiology do you think have benefited the most? What do you think are most conducive to being helped by AI currently? Is it the image interpretation? Is it the language? Or is that one modality better than the other? Where do you see that radiologist workload will decrease with respect to certain areas?
It's a very funny phenomenon, because the area in which the rest of the world believes that AI will have the greatest impact is image interpretation, right?
Yeah.
You talk to your aunt, cousin, random person on the street, venture capitalist, business guy, whoever, and they will ask you, well, has the AI replaced you? Are they reading the images? Do you even need to look at the pictures still? But as radiologists, and I think largely you've seen this pattern throughout healthcare, that's the sexy stuff, but where it's actually starting to make the most impact is, the boring operational stuff. And for us, it's a lot of the text processing stuff, right? It's so how are reports being generated, as an example? And there's multiple players out there, commercial vendors and even homegrown tools that are helping shorten the time required to interpret certain studies. I think outside of imaging, things like scheduling, things like protocol automation, a shared passion. Those are places where AI is basically ready, can go, and is having impact. Even in boring things like, chatbots for appointment reminders and for translating reports into human readable formats or content. That technology is all there and it's already happening. Whereas the clinical AI is happening to some degree in the image interpretation, but it's happening in very niche pockets, and we could debate it, but it's not really moving the needle significantly in terms of the way in which radiology is practiced and necessarily the quality that patients are experiencing.
Let's talk about the challenges in image interpretation a little bit, but to talk about the language part of it, you're absolutely right. People completely forget about how important that component of radiology is. Even when dealing with fellows, they're very interested to know, oh, this is T1 hyper, T2 hypo. But at the end of the day, what output are you giving to the clinician? That's what's more important. And to reach that output, as you point out, so many things need to be done. So currently, we are actually piloting an AI program to optimize patient imaging slots for outpatient CTs.
Yeah.
With the added flexibility that whenever an urgent outpatient comes with a recently diagnosed cancer, which needs staging urgently, how can we fit it in? So giving AI the training to be flexible, that's great. The second one, when you pointed out, like protocoling and report editing. So I know that there are a lot of already available commercial AIs available, like Rad AI, and even PassScribe has its own way of in which you free text and it just populates it. But stuff like that can actually be easily done by people in institutions if your institution doesn't actually have the capability of paying for all of this. Ultimately, it's just an LLM, and all it needs is very good prompting based on whatever your institutional guidelines are. And so we have set up something very similar in which we have a protocoling engine, which we are actually integrating into our homegrown packs, in which all information which comes from the clinician is just thrown into the pipeline, and we're able to get the necessary protocols. And then we're able to free text the reports, and it just arranges it into that. So it's amazing what we're able to do with text. So do you think that the reason for all of this is creation of these strong foundational language models, which is only possible with large amount of data? And do you think that that is the challenge with image? Because we don't really there have always been claims that, oh, there's this amazing imaging, foundational model which has come, but it hasn't kind of panned out. Do you think that it's just that fundamental difference, which is still not, that's why imaging AI has not reached its apex at yet?
So I'll agree with you on the one point and then maybe challenge or on the second. The first, I agree with you wholeheartedly. And when we think about radiology as radiologists, when you first come to the game, let's say, you just think you're very narrow and zoomed in. It's image, report, done.
Yeah.
I think, and this is how I came to it, and it sounds like maybe you as well, this whole AI space, for lack of a better term, is very much a quality lens. And, as an engineer coming to radiology, and ACR actually articulates it well, this whole imaging 3.0 and the whole value chain what is actually required to deliver a report, and making sure the physician and the patient understand that report at the end, from the time a patient sees a clinician in the first place and they're considering an imaging study, right through the end, and appropriateness and scheduling, etc. Every step along the way, including, optimizing the grid for MR or CT, right? There are tons of steps along the way, and some of which have the opportunity, especially for an expensive thing like an MRI, the opportunity to create much more value, per line of code, so to speak.
Yeah.
So I think that's an important lens for radiologists and any radiology trainees to have when coming to the practice. It's not just about looking at the pixels and generating the report. And I think that, having that, a wider lens means that we can, as radiologists, play a better part in kind of changing the system. And you have to be able to see that whole system to do so. On the topic of like, the models are so good, we can just do it ourselves. Why aren't they adopted? I would push that, and you've seen it through the different iterations of the different types of models, that the problem is not in the technology per se and the ability to classify some abnormality up to 85, 90, or even 95%, we'll call it accuracy, whatever that means. The problem is the kind of that last mile, the edge cases, what happens when these models don't perform well, and what guardrails do you need to put in place. And the problem in healthcare is that the risk, the stakes are so high that you have to get that last 5%, 3%, 2% right. Otherwise, those can be catastrophic in the sense of, obviously for patient outcomes, but also for, liability and cost and risk. And if you interact with, most health system administrators, their tolerance, especially in Canada, for risk is, about as close to zero as possible.
Although it's not exactly the same, you can see the parallels in self-driving cars as well. Even as a whole, if we figure out that, let's hypothetically say the human error rate, at least for imaging interpretation, is 4%. Let's say that we have AI or like self-driving cars, which will have error rates less than that, maybe 1% or 2%. We would think from a population perspective that that's fine. It's actually better. However, when you think about it on a per incident basis, it's very difficult to fathom. It kind of conflicts against, what's free will and that, I think that's where it becomes challenging. And the other aspect of this is that AI is not very deterministic. So how does that factor into all of these regulations? Because you could have created an amazing product which works well 99.9% of times, but one minor upgrade or one something changing model weights might just throw the whole thing out of whack. How do you put in guardrails for that to make sure that, you're not breaking it each time, you're just iterating on it?
Yeah, it's a it's a very difficult question. And the problem with the technology, to some degree, to the question of how do you kind of put on these guardrails and manage these errors, the problem is that problem keeps changing, right? So the deep learning approach to that problem is quite different from the large language model or vision language model approach, right? Because in the era of deep learning, when, let's just say it was single or multi-class classification that we were talking about in some computer vision problem, we knew that the main source of error was, just misclassification, basically. And we had approaches to try and remedy it. We could show more examples, right? We could refine the classes. We could, change the model, etc. And then we knew the forms of the errors that could come out. It could only be the wrong class or the right class. And we could put some guardrails and maybe confidence intervals, etc., to help mitigate that risk when the AI interacted with the human. Fast forward not that long, months or years, depending on how you look at it. Now with these vision language models, yes, on one hand, you can collapse them to classification problems. But on the other, especially for some of these other tasks, the way in which these err are even more unpredictable, let's say, than before. We have the hallucination problem, right? We have, problems with, context windows. We have all sorts of reasons why the models can fail that are new, that we now have to figure out new guardrails for, right? And so what are the regulators doing? Even with all these fancy large vision models and foundation models, at least and in the US, I will say it sounds like there's a little bit more ahead of the curve than we are. They have two different approaches. One, you can either collapse the problem to a binary, to a classification problem.
Yep.
So it's, and they're going to look at each task. So like nodule detection or hemorrhage detection, even though the foundation model could do 100 different tasks, each task is going to have to be, approved
separately.
Or they're saying, in certain areas, we're just not going to regulate because we don't even know how. Which is an interesting approach.
Yeah.
Comes with its own, benefits and risks. Mm-hmm. But I think this is the uncertain universe we're kind of entering. And, it's going to be very interesting.
Yeah. Navigating this is kind of very tricky, interesting, and exciting at the same time. And, I think, it's been overstated these days. It's almost become a cliche, but at the end of the day, we keep saying it. And I do think that at least for the next 10, 20 years, that's going to be it, that AI is not really going to be a competitor. It's going to be a co-pilot.
Yep.
In which we're going to navigate things together, more a collaborator, as you will, decreasing the burden on us. So what currently, especially at least in the US and even in Canada, we have a significant shortage of radiologists and doctors, and we are always overburdened with exponential increasing wait times as well as the number of scans to be read. So given that there are some regulatory hurdles, but there are some opportunities as well, how best can we leverage it to manage workload, make life easy for us?
I think it's first important to acknowledge that it is a real problem that radiologists face here and south of the border. Is we have, in some ways, it's a good thing. We have created a demand for medical imaging because we have shown, and not just the radiologists, but the entire ecosystem of vendors and clinicians, that we can solve real medical problems and prevent disease and treat disease much more effectively with technologies that didn't exist 50 or 100 years ago. So Absolutely. It is insane to think about, right? From a historical perspective. And, what you do on a daily basis now to somebody 50 or 100 years ago is, complete science fiction, right? So it's important to have that perspective that this is a good thing, that we're not just, as one of my colleagues at William also like to say, like tapping on people's chests with spoons and listening for, the pneumonia. But now we can stick people in a machine that actually quantifies and, what's going on inside a patient, and we can actually make better treatment decisions. So that is a good thing. But, the consequences of that is that there is so much demand and not enough radiologists. Radiologists take a while to train, and there's a lot of images that need to be read. So it's a real problem. To what to do about it, I think it comes back to a bit of our imaging 3.0 view of kind of end-to-end value stream of radiology, is to say we need to, if we're just focused on how do we read this one image better and faster and quicker, I think we'll miss some of the opportunity to rethink how it is we deliver our care to patients. Because, the real opportunities and risks from the patient perspective around AI is that, AI is a super enabler. It gives normal people superhuman capabilities. It doesn't always help the expert that much. Right? So the radiologists are the experts. And right now, the public, the regulators, they're demanding that the experts read the images, and that's who's taking liability for it. And that's what people want. But you can see it happening, with not too much of an imagination, where, we'll say, society at large, the public at large, are okay with a non-expert interpreting the image as long as they have AI with it, because that combination is just as good as an expert radiologist. You could even see a step further where, especially if you see the susceptibility of the masses to good marketing, where there's a story being told where you don't need either of those. You can just look at just, stick your body part in the MRI machine and the AI is going to give you a report. The public has no way of discerning whether it's better or worse than what the radiologists produce, but they get it fast. They probably get it cheap. And so maybe at some point they stop caring.
Yeah.
Right? And I think that's the real risk that radiologists and maybe medical imaging as a whole needs to have an eye on is when people ask me, what am I most worried about? It's not, is the technology going to get better at us? Is the public going to stop caring about the difference between what they get from a radiologist and they get from the AI machine or the AI plus somebody in between? So I think to answer your question, we need to be cognizant of that as a true alternative universe that could exist and does exist in certain pockets, especially in unregulated places, that we need to constantly be thinking about how do we deliver, better value to our patients and what does that look like, right? And sometimes it requires us kind of disrupting ourselves, right? So if you think about, let's just say, I've talked about like screening tuberculosis is a great example, right? Right now, let's say in Canada, probably, I don't know how many thousands or tens of thousands screening x-rays are being done for tuberculosis, right? And that has like a certain dollar value that is assigned to a radiologist in the facility doing it. But you and I both know, and the World Health Organization has declared as such, especially for the task of, is there like evidence of TB or not?
Yep.
AI is just as good. And it's going to be way faster and way cheaper, right? And it's actually acceptable from WHO perspective for screening, which is quite interesting. So the question is like, is a radiology group or practice going to just keep billing whatever amount for screening x-rays? Or is somebody say, I'm just going to do them all, right? I'm going to do it for less than we currently bill, but we're going to make sure that we as experts know how to supervise this algorithm the best and make sure it is as high quality and that you get the turnaround and the service that you want, etc. You're going to make your revenue is going to be less, your profit may be the same, or even more perhaps, but you have to undertake that activity of like disrupting your own, workflow, your own business model. So it's going to be interesting to see who's willing to kind of adapt in how they practice and use these tools, and find new ways of delivering value to patients and payers, etc. And who's going to just kind of keep working in the old system, so to speak.
And we know how that ends, right? Like a lot of things which continue to do the same way kind of go out like Nokia and Kodak, I guess.
Yeah, but it depends on your time horizon too, because
true.
if you 5 or 10 years, you might be okay, right? But if you're just starting practice now, the world could be very different in 20, 30 years.
Absolutely. But this is something which is very important and close to my heart as well. One of the main reasons we started the podcast is for people, patients, trainees, other physicians to know that there is a face and a brain behind the images. Because a lot of times patients feel that they walk in, they get the scan, the report pops out, automated. And the difference between, as you point out, whether it's coming from an expert versus AI plus not that great an expert versus completely AI is just lost on them. 2 days ago, I saw a viral video it's a short on YouTube. It was a physician from the US. It's a board certified physician who was telling patients that, hey, if any of your physician, like somebody, they ask you to get imaging done at one of the academic centers, tell them no, that you'd have it in a private center instead because it's faster, it's cheaper for you, for your insurance and all that stuff. However, a physician is missing the point that maybe a general radiologist reading for a general issue might be okay at a private center, whereas the level of expertise at an academic center for niche areas and questions are absolutely essential for that particular population, and that kind of dichotomy is lost. And I think that this is kind of where you point out that as an expert, you're better at reading and understanding those edge cases. But where do you see that things evolve? Now, for example, as you point out, back in the day, clinicians used to take a spoon and be able to diagnose pneumonia. We don't anymore because things have evolved. And where do you think this would go if more and more AI is being incorporated? Do you think that a radiologist being trained 20 years later, would he be as good as identifying these edge cases? Or in other words, when we have these self-driving cars, initially we knew that they were causing all issues. Nowadays, all they're saying is that you can just leave your hands off. All you need to be doing is looking at the road. But do you really think that someone who's driving for 4 hours is going to be looking at the road nonstop while not doing anything? You know that attention is going to wander. And as we get more comfortable with AI being good, would we be as good in detecting these edge cases as we are now currently?
Yeah, a lot there. The first part on, how do we, as radiologists, kind of deal with this communication gap with patients, with providers, with payers. It's a real challenge because, to your point, we're experts in, and we're trained to look at pixels and generate a report, right? 5 years of training and 6 years, 1 year fellowship or 2. The thing you're drilled into your head is read an X-ray, read an MR, generate a report.
Yeah.
Do that at high quality, do that at efficiency, but that's it. What you're describing is a completely different set of skills that I don't think they teach well enough in medicine broadly. And so, we benefit greatly from, I think, a few leaders in the space, and hopefully podcasts like this can encourage more of them who are willing to kind of step out of the dark room and communicate and engage patients, speak directly to them, to payers, to providers, and say, hey, this is what we do. This is how we can help. This is useful. This is not useful. Here's where the future is going, et cetera, et cetera. So I think we are very much. We all benefit from the few leaders, I think, who are willing to do that, and hopefully we can encourage more and more to do so, especially in a specialty that historically attracts people, frankly, who like sitting in the darkroom and reading their X-rays. So that's an inherent challenge for us versus a lot of patient-facing specialties. I think to your second point is a very interesting one, is this, which is well known basically in the field of engineering, but is novel to the idea, to the field of AI, which is so young, which is the entire complexity of this human-computer interface that AI plus radiology really is, or AI plus radiologist really is. And what you're describing there is this idea of, within human factors, let's say, and this idea of complacency, right? And it's been shown, and we know this from, you can see it yourself even with tools like Waze, where at first you're maybe a little bit skeptical, and you don't trust it, and you've heard on the internet that, somebody drove their car into a lake, and you're like, that's ridiculous. And then you start to learn optimally. You're like, okay, I start to trust it a little better, and, I'm going to follow it because I think it has a better route, etc. But then you can kind of go too far where you believe it has almost this like omniscient, property to it, that it knows everything. Yeah. And so it's always going to be right. And I see this with my kids, right? Who believe that Waze knows more than I do when driving like a route that I've done 100 times. And, it takes a certain level of insight and knowledge and experience from having lived in the pre-Waze world to know there's not enough volume on this side street, as an example, of Waze users to even know that it's going to be slow.
Yes.
So it's showing that it's going to be faster. But I know that it's going to be busy, and there's going to be a lot of stop signs, and there's kids and all sorts of things, that's going to be the wrong way to go, because I know things that the AI doesn't. And you need that certain level of insight to understand how Waze, in this case, or any AI tool, is trained or developed, and what data it's incorporating to know what sort of result it's producing and how much weight and gravity you can put to it. And I think the same thing is in radiology, right? Where right now, for radiologists like us, I'll say, we've lived in the pre-AI world, so we understand the limitations of interpreting certain types of tests, etc. and what they can and can't do, what data is required to do it, what a good acquisition looks like, et cetera, et cetera. And so if we see an AI result that spits out, for example, and it says hemorrhage, but we recognize that on a head CT is really just artifact.
Yes.
We're very confident in dismissing that. Fast forward 10, 20 years where everybody's trained supervising a bunch of models. The question is, how do you develop both the expertise to recognize all the ways that tools can err, plus now the expertise required to manage a whole bunch of new AI tools that can do, that have characteristics that you and I can't even predict right now. So I think it's a real problem, and you see it happening because at the end of the day, we are human as radiologists, and we will get complacent when we see the tool works well enough. We start to just trust its output, and this has been proven in mammography. We've seen it in head CT, where what can happen, especially if you don't monitor these models, is performance may be good on day 1 when you go live, maybe even day 10 or 100, but something might change in the data, something might change in the model.
Yes.
That
model drift.
Yeah, model drift, data drift, either one, that results in an output, a prediction that is no longer, safe or high quality or correct, and is an error, and the people don't either know to recognize or are too complacent to even bother thinking about it, right? So it's very easy to predict that into the future, and I think we're going to have to figure out ways of practicing as radiologists that, just like we have satisfaction of search and other types of heuristics that we know about that we actively try and prevent against, we are going to have the same kind of automation bias problems that we will encounter when we start to deal with these different AI tools, especially as they increase in number and we increase in our experience with them.
Yeah, so that is very interesting because we always keep saying that a radiologist who competes with AI is going to die. One who kind of works with AI, collaborates with AI, is the one who's going to come out ahead. However, in our discussion, I think we agree that it's not an AI who's just going to collaborate and just trust blindly whatever the AI is saying and just use AI. It's going to be a radiologist who knows what its limitations are, what its biases are, when it can make mistakes. So in a way, you need to be better than the AI. It kind of pushes you to be better. You just can't be middle of the pack. I'm just a safe radiologist anymore. You need to show that you're good and you're better than AI so that you can identify those areas where it slips up. And that might be a lot of ways in which you're a really good radiologist, or, as you point out, you have understanding of the inner workings of AI so that you understand where its limitations are, where its biases are, which ones it does a good job, which one it might not. And knowing that, then you kind of incorporate it. Which I think that it means that all of this has to be inculcated, should become part of radiology training. So how do you think radiology training should be structured, incorporating AI, especially for the new trainees, medical students, and fellows?
I think the training question that you ask is a very important one and a very difficult one, because whatever we're about to suggest has to lie on top of all of the skills already required to become a competent radiologist, which is no small task.
By itself,
right?
Yeah.
And already we produce radiologists, right, with a distribution of skills and quality, etc. And the question is, how do we do that and then layer on the AI on top? I admit that I don't know the exact answer to this, and there are people who have spent a lot more time thinking about it. But I think what you're suggesting is, directionally correct in that, one, I think AI tools actually can help lift the bar, or at least lift the floor of quality for a number of, probably for most radiologists in certain tasks, especially ones they are not an expert at. And I think that is a good thing. So I think if people train next to an expert, neuroradiologist, and they have both their interpretation plus an AI interpretation plus an expert, and they can learn from all three, I think that will raise the bar, so to speak, and it'll probably raise everybody's bar. And why that's important is because these AI tools, there are certain tasks, you have to learn which tasks, as you've alluded to, they excel at and where you can trust them more. So like bone age, why are we even trying?
Absolutely.
Right? And then you have to recognize scenarios where the expert can often override, right? Yes. For various reasons, whether it's more clinical history or things that are outside of the images, like is that a hemorrhagic cyst or an endometrioma, let's say, or a tubo-ovarian abscess. You can tell because of the history more than just what's in the pixels.
Absolutely.
And so, I think radiology trainees need to learn that A, difference, and then B, the idea of the different ways that the models err is important to understand. So I should say, the ways that humans and models err is different, right?
Absolutely, yeah.
And so I don't think it's fair to say that the radiologists need to be better, per se, but they need to understand how humans make errors and how these models make errors. Because it's interesting, I always find the most interesting work when we do a lot of external validation work, so pre-deployment evaluation of commercial AI tools. Before we stick them into the workflow, we want to make sure, does this work on the whole population, on different subgroups, for bias, etc. And then we get kind of a statistical output showing performance in different classes, and it gives you some color of what's going on. But really, the real value that you learn from AI is when you do these audits. Okay, you go case by case,
yes,
and you say, what did the human say? What did the AI say? And what's the source of this discrepancy?
Yeah.
Who's right? Who's wrong? And often they may be both right to some degree. They might be both wrong. A lot of it comes down to how do you define a certain class, for example. We did a lot of work with head CT, and you see the presence of an infarct in a report, but it's called something else. So it showed up as a false negative, and the AI called it an infarct. But you can also flip it where, there's just an infinite number of scenarios by which these models can fail in different ways, and the human fails in different ways. That by itself is like a treasure trove of experiences from which to train new radiologists, right? So I think it will be very interesting to see how, in that scenario of an AI, a radiology trainee and an expert, how, if you can create these experiences, I think we will learn a whole bunch about how the models work, how we as radiology humans work, and ideally we figure out the optimal, convolution, for lack of a better word, between the radiologist and the human to maximize impact, maximize quality, safety, lower cost, et cetera, et cetera.
Yeah, it's in a way, in all dystopian movies, how to safely coexist with robots. They can easily raise your floor. As we point out, complacency does set in, but it's okay if it sets in areas where AI is really good.
Yes.
But then if you're always worried about areas where AI can err, and then we are able to beat AI in that combination of human and AI can have amazing downstream effects in which we are much more useful for the patients, much more accurate in diagnosis, and much more an integral part of healthcare as a whole. Ben, it was such a pleasure chatting with you. It's great that the great work you do, and let's hope that we keep up the good work, and in a few years, let's find a way to coexist with robots.
Sounds amazing.
Thank you very much, Ben.
Appreciate your time. This is awesome.